Welcome to Chapter 16, Nursing Management, Patients with Structural, Inflammatory, and Infectious Cardiac Disorders. Valvular disease. When the heart valves do not close or open properly, blood flow is affected. Stenosis occurs when the opening of the valve is narrowed and the forward flow of blood through the valve is reduced. Regurgitation occurs when valves do not close completely and blood flows backwards through the valve. The following slide is a picture of backward heart failure, forward heart failure, and their subsequent problems. Please review this slide to understand the physiology behind valvular disorders. The next slide shows blood flow through the heart and shows the main areas of problems that can happen with valvular disorders. One particular important thing to note is that vegetations are clumps of material that grow from infected valves. They contain bacteria, small blood clots, and other debris. They are shown here on the aortic valve, but they can occur on any affected valve. That's why it's always important for a patient who has some type of dental work and also has a valvular disorder, they need to be on antibiotics, as the mouth and the gums are a direct line into the cardiac system for infection. Cardiomyopathy. Cardiomyopathy is a disorder of the myocardium or the heart muscle that's associated with mechanical and/or electrical dysfunction. All cardiomyopathies result in impaired cardiac output because most oftentimes they affect left ventricular pump problems. Cardiomyopathy can be a subacute or chronic enlargement of cardiac muscle. It's not common, and treatment is palliative, not curative. Cardiomyopathy is classified into the following three categories. The three main types are dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. Dilated cardiomyopathy results from structural abnormalities where the heart muscle is damaged and both of the ventricles dilate. There's an increase in chamber sizes, and the left ventricular muscle has thinned due to this problem. This results in decreased cardiac output due to an ineffective pumping. The causes of dilated cardiomyopathy include alcohol abuse and chemotherapy. Symptoms include dyspnea, fatigue, palpitations, and volume overload, as the increasing venous return to the heart makes it difficult for the left ventricular muscle to pump the fluid around effectively. Diagnosis is usually found on a chest X-ray, along with symptoms of left-sided heart failure and then later right-sided heart failure. Remember, most of the time heart failure starts on the left side and moves to the right. Another thing to remember is that anytime you're doing diagnostic tests, you're always looking at the patient history to be able to understand which type of cardiomyopathy you're dealing with. Treatment for dilated cardiomyopathy is aimed at diuretics, which reduce fluid, vasodilators, which help to open up the vessels, thereby reducing cardiac workload and increasing cardiac filling time. Cardiac glycosides, such as DIG. DIG is a great cardiac glycoside. In other words, DIG is able to strengthen that force of contraction. Lasix, however, in and of itself is really not a cardiac glycoside. These agents increase cardiac output by helping to rest the dilated heart. Hypertrophic cardiomyopathy occurs usually in late adolescence or early adulthood. These are the young people who drop over dead on a sports court most often. Asymmetric ventricular enlargement of the left ventricle causes an abnormal stiffness of the left ventricle, which results in decreased chamber size and decreased cardiac filling abnormalities. The cause is usually congenital, and 50% of these children with hypertrophic cardiomyopathy have inherited it. Interestingly enough, one of the problems with this is that most children never have a cardiac echocardiogram, which will oftentimes diagnose this problem. And one of those reasons is because sports physicals don't include this test because it's expensive. Symptoms, early on, usually none, and then sometimes chest pain, especially at rest, and dizziness. A high incidence of ventricular dysrhythmias are present, and sudden death may be the first manifestation of the disease. These patients usually go into unrelenting ventricular tachycardia or ventricular fibrillation, which does not respond to early defibrillation. Most of the time, diagnosis in these patients is difficult as it's usually not caught. 36% of young athletes who die of sudden death are diagnosed with this. So if you think about that, it's 1/3. Treatment for dilated cardiomyopathy consists of beta blockers, calcium channel blockers, and for those who are athletes, restricting strenuous exercise. Examples of some drugs are Lopressor, which is a beta blocker, and Diltiazem, which is Cardiazem, which is a calcium channel blocker. These agents reduce chest pain and decrease the obstruction by increasing cardiac filling time, thereby increasing cardiac perfusion. Restrictive cardiomyopathy is rare. The ventricular walls restrict the heart's ability to fill with blood. Causes are unknown, but thought to be from severe cardiac disease, scarring of the heart, or post-heart transplant. Symptoms include exertional dyspnea, non-productive cough, chest pain, and exercise intolerance. Diagnosis of a restrictive type of cardiomyopathy is done by echocardiogram. And if you know about an echocardiogram is a test that is done, and it's an ultrasound that can be done at the bedside. Echocardiograms help us to diagnose many things about valvular disorders and are often used. The normal ejection fraction, which is one of the most important things that an echocardiogram looks for, is greater than 40% in a normal person. The ejection fraction is the amount of blood that's able to be pumped out of the left ventricle in a cardiac cycle. Normal ejection fraction, like I said, is greater than 40%. Ejection fractions of 30 to 40% or in that category usually diagnose some type of cardiac problem. And ejection fractions of 20% or less are indicative of end-stage cardiomyopathy. Treatment of restrictive cardiomyopathy usually aims at a heart transplant. For cardiomyopathy not responsive to medical treatment, surgical intervention is required. Management of cardiomyopathy includes medications such as ACE inhibitors, aldosterone antagonists, diuretics, beta blockers, and calcium channel blockers. Surgeries that are indicated for cardiomyopathies, if the problem produces an electrical problem in the heart, a pacemaker may be indicated. Intra or aortic balloon pump pulsation may be another option for these types of patients, and we'll talk a little bit about the balloon pump in class. Ventricular assist devices, or VADs, and heart transplants are some other types of therapies that are used in cardiomyopathies. Nursing management for patients with cardiomyopathy is aimed at assessment for signs of worsening heart failure, dyspnea, congested lungs, peripheral edema, and the presence of abnormal heart sounds, particularly in S3 gallop. Cardiac monitoring is critical, and treatment of life-threatening arrhythmias. Mechanical circulatory assist devices, and there are several of them. The intra-aortic balloon pump is one of the most commonly used circulatory assist devices. It's a balloon that's inserted into the aorta, and it deflates, and as it's deflated, it pushes the blood. It doesn't allow the blood to pump out into the systemic circulation, depending on how often it's inflated. This allows more cardiac filling time and decreases the workload of the heart as it reduces left ventricular afterload. Total artificial hearts are newer devices that are on the market, and also the ventricular assist device. The ventricular assist device can perform some or all pumping of the function of the heart, and it's usually inserted surgically via a sternotomy, which is an incision within the sternum. The ventricular assist device is shown here. It's connected to the aorta and the left ventricle, and blood is routed through the assist device into a pump, where the pump does some of the work for the patient. Question: is the following statement true or false? A ventricular assist device assists cardiac function by physically supplementing the pumping action of the heart. Answer is true. The ventricular assist device is a sophisticated device that performs some or all of the pumping action of the heart. Infectious diseases of the heart. Endocarditis. An infection involving the endocardium, which is the insidemost layer of the heart, is usually associated with prosthetic heart valves, structural cardiac defects, and those that abuse IV drugs, particularly from dirty needles. When a client has a cardiac defect, blood flows from a high-pressure area to a low-pressure area, eroding that section of the endocardium. One of the hallmarks of endocarditis is that platelets and fibrin adhere to these eroded areas, forming what's called a vegetative lesion, either in the heart or on the valve itself. These vegetative lesions are breeding grounds for bacteria. They erode the muscle of the heart, and they also can cause major clots. The valve becomes misaligned, and the endocardium and valve are destroyed. Clinical presentation can be vague. And remember, treatment is parenteral antibiotic therapy and/or surgery, and prevention is critical in these patients. This slide just shows the layer of the heart so that you'll have an understanding of where some of these types of infectious diseases happen in the heart. The endocardium is the innermost layer of the heart. The myocardium is the muscle area of the heart and probably one of the thicker areas of the heart, and it sits in between the endocardium and the epicardium. The epicardium is the visceral layer that surrounds the heart and allows a protective layer to be mentioned into the heart. And again, here shows the slide again with the infective endocarditis. And if you notice that there's some vegetative lesion on actually the septal wall of the left ventricle, and also these vegetative lesions are present on the valve itself. Ports of entry for endocarditis include the oral cavity, which is particularly problematic from dental procedures, skin rashes, lesions or abscesses, infections such as a cut, infections of the genital urinary system or the GI tract, or systemic infections, and surgery or invasive procedures such as IVs. Some of the key features of endocarditis include fever, chills, positive blood cultures, anorexia and weight loss, a cardiac murmur, heart failure, systemic emboli, and petechiae occur in 40% of patients. Two other key features of endocarditis include Osler's nodes, which are small tender nodes that are present in the fingers and toes due to the infected emboli from the heart, and Janeway lesions. Janeway lesions are small, painless red or purple lesions found on the palms and soles of patients with acute infective endocarditis. And it is critically important that nurses understand Osler's nodes and Janeway's lesions and understand what they are. Treatment of endocarditis is aimed at long-term antibiotic therapy. It's the mainstay of treatment, especially penicillin or cephalosporin. And this can be particularly problematic in our patients who are allergic to these types of medications, as bacterial resistance has been a particular problem in a lot of the treatment of endocarditis today. Periodic blood cultures are drawn to find out if antibiotic therapy is effective. You want to assess your patients for heart failure. You're listening to their lungs, you're checking for edema, you're monitoring I&O. And you're also assessing for any new heart murmurs, which can be indicative of a progression of the disease. Surgical management of endocarditis, if medical treatment fails, is aimed at repairing or replacing the inadequate valve. Rest is important for these patients as they're often tired, and good hygiene is crucial. Question: a patient has just begun treatment for endocarditis. The patient's treatment plan would be primarily based on the results of what diagnostic test? B. Blood cultures. Blood cultures would determine the presence of an infection as well as identify the causative microorganism. Rheumatic endocarditis. Rheumatic endocarditis is a condition that develops after an upper respiratory infection with group A strep. 3% of these infections progress to rheumatic fever. It's an inflammation that is evident in all layers of the heart, and the inflammation results in impaired contractile function of the heart because the myocardium, the muscle of the heart, is affected. Rheumatic endocarditis is characterized by formation of Ascoff bodies, which are small nodules in the myocardium that are replaced by scar tissue. And if you understand that scar tissue does not contract well, its properties are tough and fibrous, and so it affects the ability of the heart to pump. Diagnosis. The following are the clinical manifestations of rheumatic endocarditis. They include tachycardia, cardiomegaly or a heart enlargement on a chest x-ray, development of a new murmur or a change in a previous one, a pericardial friction rub, which sounds like sandpaper rubbing together, chest pain, EKG changes, and this is one of those cases where a prolonged PR interval is indicative of a problem. Indications of heart failure such as crackles, edema, poor urine output, and increased jugular venous distension or CVP. Evidence of an existing streptococcal infection, especially untreated strep. In rheumatic endocarditis, prevention is key. Teach patients to consult a medical doctor if the following signs of streptococcal pharyngitis are present so that the appropriate antibiotics can be started: moderate to high fever, abrupt onset of sore throat, a reddened throat with exudates, and enlarged tender lymph nodes. And unfortunately, many patients, because the signs and symptoms of streptococcal pharyngitis are similar to tonsillitis and other types of sinus infections, these infections often go untreated and can be a big problem. Treatment of rheumatic endocarditis, again, is penicillin or erythromycin for penicillin allergic patients. Make sure all valvular heart disease patients inform their care provider that they have a defective or artificial heart valve. They need antibiotic prophylaxis to all dental work, which really reduces the incidence of these types of problems. Infectious diseases of the heart continued. Myocarditis. Myocarditis is exactly what it says. It's an inflammation of the heart muscle, particularly the myocardium, commonly resulting from a viral infection. The pathophysiology of myocarditis is that inflammation results in cardiac cell death from the viral infection. Signs and symptoms vary, but oftentimes you'll see an elevated erythrocyte sedimentation rate, or ESR. Unfortunately, elevated SED rates can happen for lots of different reasons, and so this is a very difficult thing to diagnose because the SED rate really doesn't tell you that there could be this going on. An echocardiogram in these patients is indicated as it'll show the impaired heart muscle function and a pericardial effusion. Medical and nursing management of myocarditis includes hemodynamic monitoring to make sure that the patient is tolerating the problem, treatment of heart failure signs and symptoms, a ventricular assist device, and if no improvement, a heart transplant. Pericarditis. One of the more common things that we see in hospital settings is pericarditis. Pericarditis is an inflammation or alteration of the pericardium, which is the membranous sac that encloses or surrounds the heart. The cause of pericarditis determines its presentation. In other words, acute viral pericarditis usually follows a respiratory infection, so pericarditis can follow very many different types of things. Causes of acute pericarditis include acute MI, bacterial infections such as streptococci or Staphylococcus aureus, chest trauma, chest injury, cardiac surgery, or an implanted pacemaker, connective tissue disorders such as lupus, rheumatic fever, rheumatoid arthritis, and disorders of adjacent structures such as concurrent pulmonary disease. Fungal infections, aspergillus, Candida, nonspecific causes, cancers or neoplasms, metastasis from the lung or breast tumors commonly cause pericarditis or lymphoma, radiation therapy of the chest, renal failure, TB, and viral infections such as mononucleosis, mumps, influenza, and hepatitis B. Pericarditis diagnosis is one of the most common things you'll see is chest pain. The chest pain is persistent, it's sharp, it's felt mid-chest, and it radiates into the back. It's worse with inspiration, coughing, or swallowing, and the pain is worse when supine and is relieved by sitting up and leaning forward. The anatomical position of the heart as the patient leans forward allows the heart to actually fall back into the chest cavity, which is why the pain is relieved sitting up and leaning forward. Auscultation of the patient's chest reveals a pericardial friction rub, and this is one of the hallmarks of diagnosing pericarditis. Again, you'll hear the heart sounds that sound like sandpaper rubbing together. Another thing in pericarditis that you'll commonly see is an elevated white count, an elevated SED rate, and an elevated CRP, which are all indicative of inflammation within the heart. The hallmark of pericarditis, however, is that a 12-lead EKG reveals ST segment elevation in every lead of the heart. Most commonly, patients with chest pain or angina who come into the hospital and have an MI will never have ST segment elevation in every lead of the heart. If the patient presents with chest pain, has a pericardial friction rub, and you're seeing elevated white count, SED rate, and CRP, and complete a 12 lead, and you see the ST segment elevation in all leads, this is highly indicative of pericarditis. Again, too often these patients will run a fever with an infectious type of pericarditis. Chronic pericarditis produces signs of right-sided heart failure, such as jugular venous distension, edema, fatigue, and dyspnea. Treatment of pericarditis is aimed at reducing the inflammation in the heart, and one of the most important things that we do is assess the nature of the patient's pains and treat pericarditis with nonsteroidal anti-inflammatories. If the pericarditis is very severe, steroids may often be started, but if not, they'll respond to nonsteroidal anti-inflammatory drugs, such as indocin. Both corticosteroids and nonsteroidal anti-inflammatory drugs, however, are contraindicated in acute MI and can rupture the infarcted area. Again, you want to auscultate for friction rub, position for comfort, and monitor for complications, that sometimes the inflammation in the heart can cause cardiac dysrhythmias. Complications of pericarditis include cardiac tamponade, and this occurs when a small volume of about 20 to 50 milliliters of fluid accumulates in the pericardium. If you remember correctly, the pericardium surrounds the outside of the heart, and fluid into that potential space can cause many issues. The fluid itself puts pressure on the heart and decreases the heart's ability to pump effectively. And you don't need very much fluid in there to cause problems. Cardiac tamponade is always an emergency and needs to be treated very seriously. Signs of cardiac tamponade include jugular venous distension, as the heart can't pump effectively and blood backs up into the inferior and superior vena cava. Paradoxical pulse. The pulse feels markedly less on inspiration and exhalation, and that's just due to the changes in interthoracic pressure of the chest. Another thing that you'll hear is decreased cardiac output. The fluid that's present in the heart reduces the ability of the heart to pump effectively, and it essentially squishes the left ventricle and doesn't allow it to pump. Muffled heart sounds are a hallmark of cardiac tamponade, as it's very difficult to hear the sound transmit through the fluid that's surrounding the heart. Treatment of pericarditis is initially aimed at waiting the chest x-ray or echo to confirm the diagnosis. The doctor may order IV fluids to increase cardiac output. However, you need to be careful, because if they're definitely having problems with pumping ability, the fluid may back up. You probably will need a Swan-Ganz catheter, as the pressure measurements in the heart confirm the diagnosis of pericarditis or cardiac tamponade. After the diagnosis is made, then it's an emergent pericardiocentesis. A needle is placed in the pericardial sac, and needle aspiration of the fluid in the heart is completed. Most centers are not allowed to do this in rural areas because they don't have a cardiologist present, so this patient may need to be prepared for emergent transfer. The pericardiocentesis relieves the pressure in the heart by removing the excess fluid that's present. A nurse is caring for a client who has pericarditis. Which of the following expected findings should the nurse anticipate? A friction rub can be heard during auscultation of a client who has pericarditis. Which of the following clients has the greatest risk of acquiring rheumatic endocarditis? B. A child who's had an upper respiratory infection due to streptococcal bacteria is at the highest risk for developing rheumatic endocarditis. Approximately 50% of clients who have rheumatic fever develop rheumatic endocarditis. A nurse in a clinic is caring for a client who has been on long-term nonsteroidal anti-inflammatory drug therapy to treat myocarditis. Which of the following laboratory findings should be reported to the care provider? Long-term nonsteroidal anti-inflammatory therapy can lower platelets. This finding is outside the expected reference range and should be reported to the care provider. Remember, nonsteroidal anti-inflammatory drugs can cause bleeding, and that is because they lower platelets. A nurse is assessing a client who has splinter hemorrhages in her nail beds and reports a fever. For which of the following conditions is the client at risk? Splinter hemorrhages and nail beds and a report of fever are findings associated with infective carditis. A nurse is admitting a client who has suspected rheumatic endocarditis. The nurse should anticipate a prescription from the provider for which of the following laboratory tests to assist in confirmation of this diagnosis. A throat culture can reveal the presence of streptococcus, which is the leading cause of rheumatic endocarditis.